So today I'll be talking about the surgical treatment of esophageal cancer in the era of multimodality management. I have nothing to disclose. This is the agenda of my talk. So we'll talk first about the timing of esophagectomy after neoadjuvant treatment. And the second point will be whether to operate at all or after neoadjuvant treatment. And lastly, we'll talk about induction therapy and its consequences on the postoperative complications. So as we all know, esophageal cancer is a very aggressive disease, and the management of it has developed over the years from 2006 by the MAGIC protocol, then the CROSS, the FLOT, and recently immunotherapy has been taken over the management of esophageal cancer. The patients that we see fall into one of these three categories of esophageal cancer. The early presentation, where most of them are treated endoscopically or with upfront surgery, and then the locally advanced, a group of patients who will be the bulk of my talk today, which are most of the time treated with multimodality treatment, and then the advanced or inoperable or metastatic patients who have very poor survival and they undergo systemic treatment. So first we're going to talk about the timing of esophagectomy after neoadjuvant treatment. There are two schools of operating after neoadjuvant treatment, whether to go right away for surgery or to have delayed surgery. And the delayed surgery is defined based on studies. It's past 3 to 8 weeks after the completion of neoadjuvant treatment or more than 90 days after the completion of the treatment. So if we wait past this time, there are some pros and cons for prolonged interval after neoadjuvant treatment. The pros include the resolution of acute inflammation, which might make the resection easier, giving some time for the patient to recover. There are some studies that show that there is improved pathologic complete response with the waiting, reduced recurrence rate, and tumor downstaging. The cons of this approach is that the tumor might grow and metastasize in the interim time. Fibrosis might make the dissection actually more difficult. There are some studies that showed unchanged or even worse overall survival, and there is increased mortality and increased incidence of anastomotic leaks. We're going to start with this study, which was a systematic review that was published in the Disease of the Esophagus in 2018. They included 10 cohort studies and more than 2,000 patients in their paper. So the population were the patients who underwent esophagectomy after neoadjuvant treatment, and they compared the prolonged interval to the short-term interval. They included patients with adeno and squamous cell carcinoma. The interval ranged from 30 to 60 days. Beyond that was set as a prolonged interval. The primary outcome was 5-year overall survival, and secondary outcomes included the incidence of anastomotic complications, perioperative mortality, the rate of pathologic complete response, circumferential resection margin rate, positivity, and the R0 resection rate. So they found that there was no impact in the prolonged interval patients. There was no impact on the 5-year overall survival. There was no effect in perioperative mortality. There was no increase in the pathological complete response rate, and there were increased risk of anastomotic complications, decreased R0 resection rate, and increased positive circumferential resection margin. Then another study was published in the JTCVS in 2019. In this study, they aimed to evaluate the outcomes for delayed and salvage esophagectomy for esophageal adenocarcinoma utilizing a large national database. So they included patients with clinical stage 2 and 3 esophageal adenocarcinoma who underwent neoadjuvant treatment and then esophagectomy, and they compared the timely esophagectomy with the delayed esophagectomy with a cutoff of 90 days. So less than 90 days with the timely esophagectomy and more than 90 days was the delayed esophagectomy. So again, they concluded that the delayed esophagectomy group had higher rate of pathologic complete response, but they had higher rate of postoperative mortality. When they did a multivariate analysis, it showed that the delayed esophagectomy was actually not independently associated with decreased overall mortality. So despite the increase in the perioperative mortality, delayed or salvage esophagectomy for adenocarcinoma did not affect the long-term survival for these patients. So we concluded from these two studies that delayed esophagectomy is associated with increased postoperative complications, but may be offered to patients who do not receive timely esophagectomy after neoadjuvant treatment based on case-by-case discussion. The second topic I'm going to touch base on today is whether shall we operate at all or just follow up the patients after neoadjuvant treatment. And of course, I cannot talk about that without talking about the pre-SANO and the SANO trial. And just for everyone to know, SANO stands for surgery as needed for esophageal cancer. So in the pre-SANO trial that's been published already, they aim to establish the accuracy of detection of residual disease after neoadjuvant chemoradiotherapy with different diagnostic approaches, and to decide on the optimal combination of diagnostic techniques for clinical response evaluation after the completion of neoadjuvant treatment. They included prospective studies from 6 centers. It was a prospective study, from 6 centers in the Netherlands. The patients underwent pre-operative chemoradiation based on the CROSS protocol, followed by surgery. 4 to 6 weeks after the completion of the chemoradiotherapy, the patients underwent EGD with biopsy and AOS with FNA, and the patients with residual disease at this point without distant metastasis, they went right away for surgery. The patients who did not have residual disease at this step, they underwent another evaluation with PET scan, EGD biopsy, AOS, and FNA, which was 12 to 14 weeks in total after the completion of neoadjuvant treatment. The primary endpoint of the study was the correlation between the clinical response and the final pathological response. As we can see here in the table, the first column, it shows the false negative cases by each test. So we can see which worth of mentioning here. They started the study with the endoscopy with regular biopsies, and the rate of false negative was 31%, which dropped to 11% when they changed the biopsy protocol to bite-on-bite biopsy. The endoscopic ultrasound false negative cases were 29%, and the PET was 14%. So they concluded that EGD with bite-on-bite biopsy, AOS and FNA, and PET-CT for distant metastasis after neoadjuvant chemoradiotherapy was an adequate strategy for clinical response evaluation. And they did that in preparation for the SANO trial, which has not been published yet, so don't go look for it online because it will take you 10 hours and then you're not going to find it. So in the SANO trial, the patients underwent neoadjuvant chemoradiotherapy, and then after that, they were assessed by the pre-SANO protocol, and the patients who were found to have no residual tumor, they were randomized to either surgery or surveillance. So, as I said, the patients who had tumor, like the pre-SANO, the patients who were assessed and they were found to have tumor but no distant metastasis, they underwent resection right away. But the patients who were found to have no tumor on the first assessment, they had a second assessment with the set of tests that I already mentioned, and if they were still clean and they did not have any tumor on the second assessment, then they were randomized to surveillance versus esophagectomy. And the results so far showed that the surveillance group were not inferior to the surgery group in the overall survival. There was no statistical difference in the disease-free survival and the incidence of distant metastasis, even though it was better in the surgery group, but that was not statistically different. And there was improved short-term quality of life in the patients who underwent surveillance only. There were a few caveats to the study that we should mention. So they mixed the 2 histological subtypes, which are adeno and squamous, and we all know that squamous cell carcinoma responds much better to neoadjuvant treatment than adenocarcinoma. The patients who were found to have tumor on the second assessment, so they did not have tumor in the first assessment, but in the second assessment they were found to have tumor, their treatment was delayed by more than 10 weeks, which might have affected their survival. There was crossover between the groups, which has an effect on the intention to treat analysis, and as I said, there was higher distant metastasis in the surveillance group, even though it was not statistically significant, but it was still higher, and the follow-up was only for 2 years. So this is premature data that we should not, at this point, still change our practice based on it. And if we're considering the surveillance thing, then we have to talk about the delayed esophagectomy, the salvage esophagectomy, which we do if in the surveillance, the patients were found to have a recurrence of the tumor. So this study was done by the MSK group led by Daniela Molina, and it was published in the 2023, where they assessed the risk of salvage esophagectomy. So they included the patients with clinical stages 1 to 3 esophageal carcinoma who underwent neoadjuvant chemoradiotherapy followed by esophagectomy. Sorry. And salvage esophagectomy in their study was defined as based on one of two criteria, whether the patients had the surgery more than 90 days, so that was based on time, after the completion of neoadjuvant treatment, or after the completion if they had persistent or recurrent disease. So the salvage esophagectomy was defined based on time or on recurrence and persistency. When more than 1,000 patients were included in the study, 15% of them underwent salvage esophagectomy. The odds of any serious complications, including pulmonary complications or all complications, were twofold higher in the salvage esophagectomy group. The salvage esophagectomy patients had 1.5-fold higher hazard of death, and the 5-year overall survival for planned esophagectomy was 45%, and for salvage esophagectomy is 26%, which was statistically significant. And we can see that in this graph, where the salvage esophagectomy overall survival was much lower than the non-salvage surgery. So as we said, the overall survival between the salvage and non-salvage was statistically different. The 5-year overall survival for the salvage for time was 27%, and salvage for recurrence was 25%, which is not different. So delaying, this is very concerning, because delaying the esophagectomy had the same effect on the patient as the patient who had esophagectomy for recurrence. So delay is not good. The salvage esophagectomy is associated with higher risk of serious post-operative complication, shorter disease-free survival, and overall survival. And this is all shown in these two graphs. So the conclusion of these two trials is that surgery remains the standard of care for esophageal cancer, but other options can be discussed with the patients based on their presentation and their situations. Last but not least, I'm going to touch base on the induction therapy and how it affects the post-operative complications. This is a study that was published in JAMA in 2021, where they talked about the morbidity and mortality of patients who underwent MIE, which is minimally invasive esophagectomy, comparing patients who underwent neoadjuvant chemo-rad to patients who underwent neoadjuvant chemo only. And we can see here in this table that there was no statistically significant difference between the patients who underwent neoadjuvant chemo-rad versus neoadjuvant chemo only, and MIE was safe in both groups. In this study that was published in the JTCVS in 2018, they compared the definitive chemoradiotherapy versus neoadjuvant chemoradiotherapy followed by surgery for stage 2 and 3 esophageal squamous cell carcinoma. And they found that patients who underwent surgery after definitive chemo-rad, which is salvage surgery, they had pulmonary complications by a rate of almost 30%, anastomotic leak 18%, and overall complications 53%, and all were grade 3 or higher complications. And of course, since immunotherapy is taking over the market now for the treatment of esophageal cancer, many studies have explored the effect of perioperative immunotherapy on postoperative complications, and they all proved that its safety with no increase in postoperative complications. So we concluded that MIE is safe after neoadjuvant chemo-rad or chemotherapy. Salvage esophagectomy post-definitive chemo-RTE increases the risk of postoperative complications, and perioperative immunotherapy is safe. And the summary for my whole talk is that delayed esophagectomy may be offered to patients who do not receive timely esophagectomy after neoadjuvant treatment, with consideration of the risk of increased post-operative complications. Timely esophagectomy is still the standard of care after neoadjuvant chemoradiotherapy for patients who qualify. Neoadjuvant chemoradiotherapy or chemotherapy, immunotherapy are all safe, and definitive chemoradiotherapy increases the risk of post-operative complications after salvage esophagectomy. And with this, I conclude my talk. Thank you so much for having me speak today.